Right, hello there. How are you doing? Here's hoping that all is well with you from whatever part of the world you are watching us. This is In Focus, as always. We're coming to you live from Rwanda Television. Every Sunday we get together here just to have a conversation on various topical issues. And today in the program we are putting a matter of concern to us, social security. But of course with a special spotlight shining on the issue of universal health coverage and access. And speaking of that, there's actually a two-day meeting on the 22nd and 23rd of November here in Rwanda, the Kigali Serena Hotel. It is actually a social protection policymakers conference. A lot of conversations are actually going to be happening right there, including cancer and its implication on social security. This is a must attend or a must follow event. And of course, we're going to be center our conversation on that particular event and more. And of course, we are asking you what you think about the issue of universal healthcare. What needs to be done so that healthcare is actually accessible, and not just accessible to you, but at an affordable rate. And so we have had some tweets coming through in the course of the day. Mazimaka Christian says that thanks, Eugene, for bringing out this important topic tonight. I would add that healthcare services provided must be of good quality for a system to be called universal healthcare. So it is not just a matter of mass production or accessibility of this, but of course it has to be of high quality. Another one here is definitely on looking at the issue of sustainability of healthcare services, and then of course it has to do with an issue of the long-term cost of healthcare. And of course we want you to talk to us about your individual experiences when it comes to access to healthcare from whatever part of the world you are from. So I'll be coming back to read your tweets. All you need to do is just add that particular hashtag InFocus RW, and of course we'll be reading those tweets in the course of the program. Let me welcome on board our, of course, Dr. Richard Tusabe, Director General of RSSB. Congratulations, first of all. You sit here for the first time in Focus with a new cape. Karibu sana on the program, Mheshimiwa.
Thank you very much.
All right. Also with us is none other than Dr. Frederic Nimarubusa. Nimarubusa.
Yes.
That's how you say it.
Yes.
Of course, he's the Secretary General of ECASA, and that is East and Central African Social Security Association. Thank you for joining us on the program.
Thank you very much.
Also, we are actually going to broaden this conversation, and we are joined live by way of Skype. Dr. Mercy Korir is actually joining us from Accra, Ghana. She's actually attending a seminar or a conference on call to action on antimicrobial resistance. Of course, Dr. Mercy Korir is a medical journalist. She's actually a doctor by profession and also a practicing journalist who covers health matters. Thank you so much for joining us, Dr. Mercy Korir.
Thank you, Eugene.
Also with us is Dr. Neuihe Obina. He's actually Nigerian, and of course he is a health policy expert, and he sits in New York and works with the Commonwealth Secretariat. Thank you so much for joining us, Dr. Obina.
Thank you for having me.
All
Just
right.
a quick one. I sit in London with
Perfect. Of course. So let's start this conversation, first of all. Universal healthcare. It's where we ensure that individuals and communities are actually receiving the health services they need without suffering financial hardships. But of course, this, as far as Africa is concerned, has not been achieved, much as we've seen a lot of gains in different countries. We've not been able to see, all of this being achieved. We still have some challenges. I want to start with you, Mheshimiwa Richard Tusabe. I know you're still new in this. Probably people seeing you here thinking, we're going to talk taxes, but of course, RSSB and its social security is still also like taxes, because one, it's mandatory for you to actually contribute here and all that. So let's talk about the challenges. Where do you see us, and what do we need to do so accessing medical coverage using?
One of the challenges that we have, because if you're going to have universal health access, there are key fundamentals that you need to have in place. Mm-hmm. And one, you need to have the relevant infrastructure that is going to support the service that you're going to be offering to the universal health mm-hmm. access. Mm-hmm. But number two, also you need to have the people behind this infrastructure.
Yeah.
In terms of the doctors who are offering the services. So what we are seeing a big gap in terms of affordability.
Yeah.
you need to appreciate the fact that we still have people who, I must say, are poor, and you want to give them this service.
Yeah.
So for you to offer them the service at an affordable cost, you need first of all understand who are these people.
Right.
So categorization of your population in terms of who is who for affordability purposes is very important.
Yeah.
And if you can achieve that, then you can be able to say, how do you make sure that people who can afford are supporting those who cannot afford? Not forgetting the role of the government.
Right.
Because the government also has to touch its pocket to bridge up the gap. So for me, if we can have, if we can be able to know who is who, and have the outreach that we need to have in terms of presence, being close to the people, then we stand a chance of really achieving the universal health access.
Right. Of course, let me just also bring in Dr. Frederick here, because you are now the Secretary General of ECASA, outgoing, I know. But of course, many people might not even understand of the gaps that we have, one of them being infrastructural gap and the gap of the people who are supposed to sit behind that infrastructure. Your institution come in, and where have you been in terms of trying to fix these gaps that Richard talks about here?
Yeah, thank you very much. That infrastructure is a key, but also we need doctors, we need nurses to give a good quality when it comes to healthcare.
Yeah.
But the very difficult one is how to manage this financially, how to make it financially accessible to everyone. And that's where ECASA come in this region.
So you bring the money, or you coordinate the money?
We are an association of 31 schemes covering 9 countries. And what we are bringing in this industry is, first of all, to bring the knowledge. To bring the knowledge, we train all the people who are working in social security. We bring also conferences to make policy change. That's why we are here in Kigali for this policymakers conference and to tackle this issue of universal health. Exchange best practices and take resolution.
Right.
This is really a time for action, and I hope that during those 2 days, debating and exchanging best practices will come up with really resolution that will help our leaders to
take action.
Yes, yes.
Right. Dr. Korir, I want to bring you in on this particular part of the conversation. Dr. Frederick says it is time for action. And of course, we've heard from Richard, who says that we still have a gap of infrastructure and even the technological know-how for those who are supposed to use this infrastructure. But when you talk about the money part, we understand that universal health cover is actually one of President Uhuru Kenyatta's big 4 agendas. But when you look at the budgetary allocation for this particular sector, that is the health sector, it falls short of the Abuja Declaration of 2001, where they're supposed to actually allocate about 15% of the national budgets towards the Ministry of Health. I want to read your thoughts, coming from Kenya personally, and also being a person who's traveled around and looking at these issues of financial gaps in the health sector. Do you, in terms of allocating and walking the talk when it comes to the declarations that they make in this sense?
Well, I don't even know where to start having this discussion, because one of the things that we usually run are at risk of making is looking at health as an entity where we are looking at curative services to people, as opposed to that whole continuum and whole spectrum of preventive point of view, all the way up to even and rehabilitating and hospice care for those that we run the risk, Kenya, but Africa, looking at health from that point where we need the services on one is, listening to the other panelists have rightly out that, well, we have structural deficit from the human resource and even from the commodities and equipment that are available. But if you look at that discussion, we're looking at health from an endpoint where we are looking at people who have ended up in hospital care. Who takes care of the other ones from a preventive point of view, promotive point of view, the public health? Who takes care of that? You see, when you talk about their and the allocation of finance, when this, like about 6% for the national county governments have been doing about 5% of their health. Most of this goes to what recurrent expenditure, staff, and whatnot, and very little goes into development. And all they put into curative services, never look at a preventive point of view. Right. So when we look at universal health coverage, then we miss points because universal health coverage in is a tripartite. One, affordability, as the third one. Two, availability of services as the second one. And first, the affordability of these services. So, bottom, when you're looking at affordability, then we run the risk of actually providing universal health coverage, and it becomes sort of like the in thing. Wow. I like the fact that Kenya, the president and the government has put its faith behind it because the political will in anything in Africa is quite important in making sure it's achieved. But other parts being given that opportunity to actually craft something that work and to will be sustainable in the long run.
Yeah. Okay. All right. Dr. Mercy, I want to suggest probably you can try and put on the earphones so that we can see if you could use the earphones mic. There's been a bit of breaking, and I want to believe that the points you're making are really, really pertinent here. You're talking to us about the importance of looking at the healthcare, not just from the end point, and of course looking at the issue of universal healthcare from a tripartite perspective: affordability, accessibility, and availability. Let me bring in Dr. Obinna here, because Dr. Obinna, 2001 is actually when in Abuja this declaration was made as far as the allocation of funds to this sector is concerned. One of our panelists here, Dusabe, was mentioning that government also does plug in so that they actually make it a bit easier to bridge the gap between those who need this health and stuff like that. Talk to me about the mistakes we are making as governments, for example, in actually dealing with this issue of making health care accessible, available, and affordable.
Thank you for bringing it now. I'll follow from what the last panelist has said about political will. And there's no way we can discuss moving forward on UHC or what the challenges has been up until now without looking at political commitments. We've come to find out that it's an important issue in making progress in UHC, political commitment at the highest levels of government. So that's the first thing to establish, making sure that office holders at the highest levels of government are committed to achieving universal health coverage. They understand its priority. They understand that something that's an investment in their own population, and it translates into economic gains as well. Now, understanding it and making political commitment is the first step. Also, backing this up, the right finances and right of money in the budget is the next step. You right mentioned that many of short 2001 budget declaration around how much should be made, about 15% of total government expenditure on healthcare. That's the first thing. The next thing I think countries also need to look at is to define what UHC is in that country level context. If we're not careful, at risk of making UHC something like health for all 2000, where we just talk around idealistic goals without really coming down to say exactly what does UHC mean for people in Rwanda, in Lagos, and Accra. Defining a basic package of what comprises UHC is critical to helping us then finance It's going to look different in different contexts. And so understanding what it takes to pay for those basic services for each population subgroup is important to help in. So two things that we need to do. First is to look at the political commitment at the highest levels of government, also to define what UHC is, every country level, what constitutes basic package UHC.
Right. Perfect. I mean, let's not pick their brains from where they have left from. And of course, I think it's very important that we've heard that political will is very important here. Richard, I want to read your thoughts here, because you mentioned earlier on that, RSSB, for example, and this kind of schemes that we have, they are also aimed at, having those who have contributing to support those who may not be able to be in the right position to actually pay for medical health care. Some people have actually argued, especially those who are rich, they've always said that, look at this, is very, very unfair for us. We are here struggling, our money is chopped off from our salaries to contribute to other people at the expense of our own selves. So let's try to demystify this whole idea of having people have a scheme whereby in their salaries they have this deduction going towards this social security, and whether or not they get sick, it is still being chopped off from them. And if they rarely even go to hospital, and probably the poor are the ones who are going mostly in hospital, they have a feeling that it's unfair to us. Let's demystify this whole thing here.
Well, I think the best way to demystify this is to understand that universal health care is a social right. And if we believe that it's a social right, that means that it is a must-have. And when you look at what we are looking at in terms of the Sustainable Development Goals, you're talking of shared prosperity, not leaving any money behind, but also put it into the context that if you really want to talk about the wealth categorization of the population, these so-called people who cannot afford the health services, in one way or another, you need them. You need them as your customers. You need them to grow the population. So, in my view, I'm not saying that this is basically an insurance scheme. An insurance scheme, the way it works, it's not that whatever you put in is going to come back to you directly. But we also appreciate that it's going to be shared across the base. And the way you share it across the base, the government has to define how it's going to be shared. And for me, bringing the people who cannot afford into that pool gives us a chance to realize the shared prosperity globally. So universal health access, consider it as a social cause, consider it as a social right, and then we can enjoy shared prosperity across the globe.
Right. And of course, today we have new diseases or new trends that are coming up. Of course, Dr. Mercy is actually attending one on the issue of antimicrobial resistance. Some people have announced, chronic diseases like cancer, diabetes. But you'll find that in most schemes, this kind of diseases are not incorporated into whatever they need to actually benefit whenever they need this kind of service. And so it's become a burden to many families. So I want to read your thoughts, Dr. Frederick, because in this conference, you're going to be looking at the issue of the implication of cancer on social security. Talk to us a bit about how these kind of chronic diseases and these new trends that are coming up are affecting or disrupting the way we've been handling social security.
Before I handle that one, let enforce this idea, saying that social security, universal health coverage is a human right, enshrined in the Universal Declaration of Human Rights, enshrined in our constitutions, and it's really an economic necessity, a social necessity, and a moral obligation. It's a question of solidarity. If you see someone who is sick and he can't afford to go to see a doctor and he's dying, losing his life because there is a lack of solidarity. Let come with a a social health insurance scheme, mandatory for everyone, mandatory for those who can afford. And those who can't afford, then the government come in with a budget, tax-based contribution. And then we make a large solidarity between our population. And I like the way Richard said it. We share prosperity. We share prosperity.
Yeah.
But we have also to ensure that those who are paying are getting
value for money.
Value for their money, good quality when they go to hospitals.
Right. Over to cancer now.
Yes.
New trends.
Over to cancer. Cancer, diabetes. These are now, in Africa, it's a big burden now. Then if we don't use solidarity through health insurance and mandatory through health insurance, large solidarity, we can't come over those diseases. That's why with mandatory, compulsory social health insurance, I'm sure Africa can overcome with those diseases. Like Europeans have done. We are not inventing the wheel.
Yeah.
They go through social health insurance. Those who can afford can go to commercial insurance. But mainly, our majority of our population are living in the rural areas, in the informal sector. They have limited means. Then you have to pool all the contribution, then to support those who can't afford.
Right.
Yes.
Of course. Dr. Massey, I would love to bring you in on this one before we let you go, because you need to also attend some of the events that you are there attending. Talk to us a bit about what you've just heard from Dr. Frederick, speaking about the trends that are changing and, of course, using social security to actually get treated for these new diseases and this trend of chronic diseases like cancer now. How realistic is it? I mean, looking at the background of Kenya, for instance, how easy is it for someone or having a relative suffering from, let's say, cancer, diabetes, to use social security fund, not the commercial insurance, for treatment? And can we do this? Can we have this happen for those who can afford these prices?
Well, it's definitely something that is doable, but worldwide, and it's not just something that is unique to Africa or Kenya. Treating cancer is an expensive affair. Cancer has rendered some families poor because they sell all that they have in order to get cure. So it's an expensive affair that, well, the people who craft the insurance covers or how to pay for it really need to know or see how to balance. But ultimately, when cancer is got early, like in stage 1 or stage 2 of the disease, then it's easier to provide care, which may be cheaper. The other aspect of cancer care that we forget is usually the palliative and the hospice part of cancer. You probably have heard, and it is the situation in Kenya, that most cancers are diagnosed late, when people are in stage 3, stage 4, and most of the time, from a medical point of view, it's really difficult to reverse the damage that has happened at that time. And these are people who would benefit more from palliative care and, from hospice care, where their pain is managed and they're given a better quality of life, even with the cancer, which is a sector that we don't really talk about much. Now, when we look at insurance, you asked a very good question, and we get a lot of this from even my fellow Kenyans and people across Africa that I've interacted with. That why I never get sick, why should I pay insurance? And the example I like to give is for people who own cars, for example. You pay for insurance cover of your car so that in the event of an accident, you don't suffer catastrophic expenditures for repairs or even for replacing a car, which is the same thing with health. You never know when you will get sick, and it's not just about getting sick. You may walk out and usually give an example, slip on a banana, then you fall down, you find yourself in an ICU, for example. So you never really know. So people should be sensitized to know that you're not paying an insurance, for example, for you to get something back out of it or, to get refunded. That this is just a cushion so that in case you need it, then you're cushioned, which is one of the things that everyone should be sensitized about. Now, ultimately, for healthcare to be a basic human right in Rwanda, in Ghana, in Kenya, Uganda, Zambia, anywhere. It has to be from a public point of view, and it has to be government driven, where either it's tax funded or those that can contribute to a pool that then goes to everyone else. And I'd like to give an example of last year when you had cholera in Kenya, and it was from a big hotel, one of the I think it's a 4-star hotel, that all these doctors and dignitaries were attending a conference, but they suffered from cholera. Why? Because the system is broken. If it's not publicly driven, then the private sector that are capitalistic and that are looking for profit will drive everything in healthcare. And so that's why you'll find private insurance premiums are high, they are out of reach for most, or they cover a limited amount for people. So it has to be really public driven, government driven, for it, one, to be sustainable in the long run because healthcare is expensive, and two, if we are going to leave no one behind, then we can't rely on a privately funded healthcare system that is for profit.
Right. Of course, before I let you go again, I mean, while you're still at it, as a doctor yourself, there's been also thought that doctors have less incentives to actually provide quality care if they aren't well paid. Of course, they might also spend less time when it comes to dealing with a patient so that they can keep their costs down. Of course, this has been seen in some cases where someone comes with RSSB or the local insurance, not the commercial one, and they're treated sort of differently from someone who comes with cash. Talk to us a bit about how that affects the industry as far as access and affordability and availability of healthcare is concerned for normal citizens.
This, Eugene, drives to the point that I was making about healthcare being, if it's private, if it's primarily private, then the people that are there are out to make a profit, and unfortunately will take advantage of you and I who may not have an idea what is happening in the sector, because you've gone to a hospital to seek for care, you've gone to a doctor, a nurse, anyone to seek for care, and then if their motive is profit, then they will take advantage of this. But if it was on a public scale where everyone gets treated equally, regardless of what insurance they have, because all of us have the same, then we wouldn't have this. And we see a lot of these things happening, and I think, unfortunately, and I may be biased here, blame doctors for taking advantage of patients, for, going on strikes because they have better pay. Let me give you just a brief history from Kenya. By the time I was finishing medical school, that is 2011, a freshly graduated doctor was earning an equivalent of $400 US. And they work for literally 24/7 hours a day. Now tell me, with $400, and this is some people who have families, who need to live, they need to eat, they need clothes on their back, they need to find a way of going to work. Tell me how they will survive with $400. So that's why there was a clamor of improve doctors' pay, improve nurses' pay, improve the clinical officers' pay, so that they primarily focus on taking care of the patient. And you'll find now in Kenya, the doctors will say they are not yet there, but they've come a long way to a point where, in my opinion now, the focus should be on improving healthcare, because they have been more or less well taken care of. And when you remove that headache of, it's basic human needs, where you need to take your children to a good school, you need your children to eat well like all other children.
So basically, they need to be incentivized.
Yes, so that now they remove themselves from the equation and focus on providing care. Right. And that is one of the gaps that Richard had talked about infrastructure and having good human resource. It's not just about the numbers and putting them in the health system, but are you remunerating them well? Are you providing them with an insurance, for example? Are you making their access to hospital easy so that they can provide services when they are needed? So this gaps are not just about the numbers, but about motivating and incentivizing the healthcare worker so that they can provide these healthcare services. So when we look at the whole picture of universal healthcare, it's not just about putting in money and expecting changes, but we also have to work with the human resource so that you work with them along the way if we are to get good outcomes and a better health system. And it's something that should be all across Africa, not just in particular countries where you say these ones have made strides, will never make it. They should be all across board, Eugene.
Right, perfect. I want to release you. If you feel like you want to go on staying with us, feel free to be with us, Dr. Mercy, but thank you so much for your insights, for being with us. I want to just jump over to Dr. Obinna before we come back to the studio guest right here. Still picking on Dr. Mercy's thoughts right there on the issue of remuneration of doctors. Of course, your thoughts and probably what needs to be done for us to actually to sustainably finance, for example, the healthcare systems that we have. What needs to be done in this particular case so that we are able to, sustainably have doctors who are well remunerated and also still have them doing what they need to do? Because in most cases, we've had people say that being a doctor is a calling. It's not about thinking about the money, but saving their lives should be their first priority. If you're still there with
Okay, thanks. As a calling that should come with its financial rewards as well. So talking about how exactly to best finance the system, we realize that public sector financing by using steady income streams has been the best way to finance going forward. When we look at other economies that have made a lot of progress in universal health coverage, we see that there is compulsory payments driven through the public system that goes into financing the entire health system. So that's what we've seen that works. There are different models and there are different ways other countries have tried to look at what works best. But ultimately, we need one regular stream income that is usually channeled through the public system.
Right.
And to cover as many people as possible, because insurance is a game of numbers and it's all about risk. The more we have in the pool, the better we can understand the disease patterns and the more we can plan financially. Now, quality is an issue that has been looked at in health systems as well. And that is so important for us in addressing issues in universal health coverage. Now, there have been talks about different kind of care given based on the kind of insurance that patients have come with. This is sadly not new and quite common practice in many places across the continent. What needs to be done is to look at the reimbursement models for our health insurance system.
Right.
What exactly drives the prescription pattern? What exactly drives the kind of care that patients receive? Many times we see reimbursement models that have served to pay physicians not just on number of tests that you've done or how many times the patient is admitted, but it's payment based on outcomes. All right. So when we have this kind of reimbursement systems that take the patient in mind and tries to reimburse healthcare providers based on improvement in the patient's health overall, we see that there's less tendency from doctors or any other healthcare professional to cut corners or to treat people differently. Because at the end of the day, the reimbursement is going to be based on the patient getting better.
Right. Okay. Thank you very much for that as well. I want to come back to the panelists right here. Of course, Dr. Obinna was mentioning numbers. And of course, when we're talking numbers, the population is actually growing as well. And as the population grows, we will definitely be able to have a strain in the way we provide healthcare to these growing numbers. For example, it is estimated that to reach 2.5 billion by 2050, this is the population of Africa, for example. So we are going to face a critical challenge of creating the foundations for long-term inclusive growth for all. And growth here includes health coverage for these people. Richard, as you sit in your new office, Does this bother you? Does this worry you? The numbers are coming in, people are giving birth, and we will need to take care of these people. They will all need universal health care. From an RSSB point of view, for these numbers that are coming up.
Thank you. I think population growth is a function of two key fundamentals. One is the fertility rate, and the other one is the mortality rate. So when you look at the trends, I think what we are seeing is that the fertility rate is slightly going down. I mean, if you look at the average family size, but also we are seeing mortality rate going down. The life expectancy is getting better. So if life expectancy is getting better, that means that, yes, you're right, there's a bit of pressure that is coming for social security funds to support the aging population. And also considering not only Rwanda, but also Africa in general, having a young age in terms of the young population, the youth taking a big percentage of our populations. So health and this social security being a numbers game, I think it's a good problem to have. We should look at it in a positive sense, because if you are saying population is growing, that means the market is growing, the economy should be growing. And it is our responsibility to make sure that the aging population is not a problem to the continent, but it's actually an opportunity to the continent. So I think one of the things that we shall be discussing in this conference, in the 2 days conference, is to see how can we engineer our pension schemes to accommodate a growing and aging population. In the future, we're going to have many of them. But also, how can we customize and prepare for that upcoming challenge? And exactly what we are talking about in terms of universal health access, it is responding to accommodating the population to grow. So I don't see it as a challenge. It is something that we should be really proud of. But again, the experts in the room need to really be thinking ahead.
They need to be thinking ahead.
Otherwise, we can have a problem. So I believe that in place, in the regional perspective, we should be able to accommodate that upcoming challenge, but it's a big advantage for Africa, and one in particular.
Right, Dr. Fred, you're the experts here that Richard is talking about. Of course, just as you come into this particular issue, I would like you also to respond to one of the things that Dr. Mercy Korir did mention, and that was the issue of the living conditions of the medical practitioners, who we still have a challenge when it comes to their numbers, as far as the number of medical practitioners that we need, so that we are able to take care of those who are unwell. She mentioned $400 per month. You need to deal with an array of issues personally in your home, and you still are requested or required to still do your services with diligence. As we talk about securing the patients, the people, when
about this issue of salaries of doctors or salaries of every public servant, it's time we really handle it. Are we paying fair salaries? Those who can allow families to live in dignity life? It's really time to look at it and give a fair salaries for not only for doctors, nurses, even other public servants.
So we might be going there and becoming harsh at them, and yet probably it is because of the money, their mafaranga.
Let me come back on this issue of a growing population in Africa and young population. This can be an opportunity for Africa. This is a demographic dividend if we have good policies. If we have good policies, especially policies regarding youth employment, we can really gain from this democratic dividend. But if we don't have good policies, this is really a very big challenge for our leaders.
So what you're trying to say is that during this conference, I see we will be having a ministerial
Summit. Yes.
So you are assuring us that the ministers at their level are going to be discussing this issue of the salaries, remuneration,
and come with concrete resolutions for the region.
Okay, so let's take a look at some of the tweets that have been coming through. We have Mazimaka Christian who says, achieving universal healthcare requires change in the way we think about health policy. Coverage is a right rather than a benefit of a salaried job. There is need to ensure access to a particular hospital, specialist, drug, and do not depend on patients' type of insurance. Richard, are you able to talk to us a bit about this? How should we expect the evolution? How often should we expect a review of the package that one gets from their social security? Like if you're covered by RSSB, how often do we review this is what you can get as far as medical care is concerned?
I think the review is to do with one of the complaints and the changes that have been happening is to do with what drugs can you access if you are a member of the insurance scheme.
Yeah.
So again, that comes with mainly in terms of at what cost and how much can the scheme financially sustain and support all these people who need the medications. So in my view, we need to, it's a moving target, but it goes back to the financial affordability of the people that we have in the insurance scheme. The better the chances of sharing and supporting everybody who needs this medication.
Yeah.
So it's an ongoing initiative that we really need to keep focus on and say, why are these drugs not part of the insurance
coverage?
Cover?
Yes.
And what do we do? Do you need to increase the amount, the percentage, maybe by 1%, by 0.5? So it's something that we really need to keep an eye on. But yes, I agree that we should not really be excluding some people to access some medication.
Right, perfect.
We need also a permanent social dialogue between all the partners, government, employers who are contributing, employees, civil society, those who are representing those who are sick. A permanent dialogue can come with a solution to handle
this particular problem. I don't know if Dr. Obinna is still with us. I would want to give you your closing remarks before we can now close with our panelists right here in the studio and a few more comments. Dr. Obinna, if you're still there with us, where do we move from here? How do we actually solve those that continue to face us as a continent in actually providing universal health coverage?
Thank you. I'm still here. I'm still here with you. First, I just want to touch a little on the issue of the population. As our experts have seen, it can go both ways. If we manage it properly, we could reap the dividends from a young population, especially economically, as respect to having a very strong workforce and people that can contribute very, very sustainably towards a growing GDP for our countries.
Right.
But if we don't manage it, it can actually be a time bomb waiting to go off, in the sense that growing populations continue to put a strain on already existing facilities and will continue to put a lot of pressure, especially on urban areas where we see a lot of migration happening, especially around the continent, moving towards the urban areas as well. So it's something that needs to be considered from those two sides and make sure that we're actually addressing the current problems that we're having. Also, with respect to what is covered, this will continue to be shaped by knowledge of epidemiology and disease patterns in every community. We need to continuously evaluate what exactly is the most common problems in every society. And that's what UEC serves to do. Is a matter of deciding how do we make sure that we have access to the most important care, covering the most common diseases in their community. So what we need to do is to define what exactly is the most common conditions, what does it cost to manage them, and then continuously review this over time, because again, it changed. We see on the continent moving from just infectious diseases to a growing case of non-communicable diseases, cancer, heart conditions, diabetes. So, and these are expensive conditions to manage. Having policies that are driven by data, knowledge of what disease conditions are in every section of the continent will help us better define what a basic should be offered to our population.
All right.
UHC is realistic.
Yeah.
Be on the path to achieving it.
Right. Thank you so much, Dr. Obinna. I want to say thank you from us here in by and say hi. Let's read another tweet right here from it's called Will compulsory adherence, subscription by citizens, and healthcare professionals' motivation are the major drivers to a successful universal healthcare system. Dr. Frederick, do you think these are just words, beautiful words on paper and not actually practiced? Is it easier said than done as we go?
No. Now, if you look across Africa, now the political will is growing.
Yeah.
If you look countries like Rwanda, Ghana, Mauritius, and even Kenya now, in their big four
agenda.
In the political agenda, there is universal. Really a commitment from our leaders, and we should spearhead this agenda.
Yeah. Rukundo Atanas says that universal healthcare means that all people access healthcare services they need without risk of financial hardship when paying for them. Health efficiency and effectiveness. Rights of the most vulnerable shouldn't be disregarded. Let's take a look at what sort of conversations. You've actually already alluded to some of them, the ministerial summit, the talk on the effects of cancer in universal healthcare services. Let's talk about more of what we should solutions. Will it just be a talking shop so that when people go back home, it's business as usual? Or what should we be expecting out of this?
Yeah, we expect that after this conference, and especially after the Minister Summit, we should already have a political change in the region where countries are going towards universal health care through a mandatory, compulsory social health insurances. This is the only way we can come up with this challenge of health care. And we will be using solidarity, and solidarity is a traditional value in Africa. I think it's really time to spearhead this agenda.
Another change we know is that there will be change of leadership at ECASA. And of course, Richard is going to be taking over, if I'm not wrong, or if I'm not breaking the news before. So Richard, as we take over this, I mean, what sort of things should we be expecting in your new term, in your mandate in this sense, as the leader of this association?
Thank you, Jai. I think as I take the new role of chairmanship of ECASA, I think one of the key things that I'm going to do, again, is to I think a good job has been done. ECASA is almost 10 years old now.
Yes.
So that's quite a young institution. So there's a lot of things that I think I'm really going to push forward. Is the commitment and the support that we need to get from each other. If you look at where we are in terms of progress as members of ECASA, some are more advanced than others on respective schemes. So we have a lot to learn from each other, we have a lot to share, but also the capacity to empower the ECASA as a framework that's going really to be a game changer to ensure that we move very fast to realize our objectives. So I intend to support ECASA. I intend to get more partners, more stakeholders, especially the governments, the development partners, to ensure that we carry our voice, which I think is a bigger voice, to ensure that we get the relevant support and try to implement all that we've agreed. We have a strategic plan and objective that we need to achieve. So I think I'm coming at a very opportune time when things are really moving quite okay, and I can commit that during my leadership, we're really going to share experience with what we are doing in Rwanda, learn from those who are more advanced, and also support that are still lagging behind. And one of the things that ECASA has, again, strongly managed to do, they've managed to have a training institute. Some of the challenge that we have, the human capital, is really struggling in all aspects of social and pension fund management. So again, I'm going to make sure that I give it the relevant weight to ensure that people are trained. So as we demand for better services, better input, better guidance, we've already given our people the relevant skills to drive to the next level.
Right. The African Union has actually instituted a sanction mechanism for countries that will not actually toe the line when it comes to the agreements that the continent agrees on. Should we be expecting such kind of things? That because as you agree as a bloc when it comes to social security issues, but those who don't and fall along the way, should we be expecting some sanctions?
Yes, absolutely. But again, we understand that some people, I think by and large people agree that this is the way to go.
Yeah.
But we realize that the sense of urgency for some people is not really that high. And possibly that comes from not understanding that this is you're touching people's lives.
Yeah.
And when you're touching people's lives, you need it to be moving a little bit faster.
True.
So, but again, the muscle that we have as a CASA membership, I think we have everything that it takes to support our people, and our citizens should be really leveraging on these benefits.
Perfect. All right. All right. Let's just read one last one here. Gentil says, my idea on this is to look deep into how we can increase number of doctors. Rwanda is developing fast to the level. Generalist consultation should actually be at the level of health centers. Of course, there are lots of other comments that have come through. Just follow that through the hashtag InFocusRW. Unless you want to just jump in real quick with one last point. Dr. Fred?
Yeah, sure. Doctors are key in delivering good services in health insurance, in the health sector. Yeah. Then we need more doctors.
We need more of them.
And well paid. Then they can be incentivized and deliver a good service.
Right. Thank you so much, gentlemen, for actually being here on the program. Of course, also thank you to our viewers and also the panelists who joined us live by way of Skype from across the continent and actually different continents for that particular matter. We want to say thank you for watching. The hashtag to follow is InFocusRW. Let's get there. Let's keep talking as the show ends here. It continues on our social media platforms. We'll be looking forward to this particular event, 22nd to 23rd of November. Of course, the outcomes of this particular one. If you have issues to do with social security, healthcare, especially universal, find your way there so that you can be able to get to hear what will be spoken there. Of course, we'll see you again next week, same time, same place. As always, I'm Eugene Anangwe, signing off.